Yes, yes, you can wait. I was
preparing to live stream.
The Pailly, yes, video. It's live.
Just a minute, ma'am. It's live.
Yeah, you invite. Yes, you invite from.
Is it visible, ma'am?
It's visible.
So good evening, the respected doctors. On behalf of Corona Remedies, I am Pranjal Wankhede, welcoming all on the session. Let's talk and walk with the legends, Dr. VP Pailly and host Dr. Sadhana Gupta. Dr. Sadhana Gupta is co-chairperson of SAFOG and NCD committee, FOGSI representative, and also vice president of FOGSI in 2016. So I hand over the session to Dr. Sadhana Gupta, ma'am. Welcome, ma'am.
Thank you, Pranjal. Stop, please. Stop slide share. Stop the share. So a very warm welcome to each and everyone, because today is a special day when we are looking to a great conversation with one of the legend obstetrician and gynecologist of our country, known all over, Dr. VP Pailly, who is known for his great innovation, not only in the field of surgery, not only in the field of equipment, but a very, very difficult task of the establishing regular confidential inquiry into maternal death, and which speak volumes of his perseverance working with the different level of organization, government, as well as the bureaucracy. Dr. Pailly has been a motivating and inspiring, very tall figure whom we look for guidance and what we can do best for our country, for women and their families in our country. It is a real great pleasure to welcome you, sir. Dr. VP Pailly, we are highly obliged to have you here, and we look forward to a great conversation which will be motivating and inspiring for all people who are listening to us today and who will be listening to us the recording of this conversation. So let me share in my FOGSI journey of the 30 years when I was very, very young and just entering. Dr. Pailly was one of the figures whom always I followed. He's a very silent person, very soft-spoken person, but how beautifully he plans the thing, how courageously he puts his point in the international forums, in the national forum. That was something amazing. And we always see the people like him who are so much having so much of commitment and conviction. So it is a great pleasure to introduce Dr. VP Pailly, and I'm really honored to have that he has given his precious time, despite he's a very, very busy consultant in Rajgiri Hospital. Thank you once again, Dr. Pailly. And actually, Dr. Pailly, the most important work, that confidential inquiry into maternal death, and he has started right from 2003 to 2004. It is actually a lighthouse for everyone, because that inert, apathetic analysis and all recommendation are they have a very, very important role in reducing maternal death, reducing maternal criticality, improving our all health statistics all over the world. It does not belong to Kerala. It belongs to all over the country, and it belongs to whole of the world. So Dr. Pailly has something done which we thought that in India we are not tuned to such type of confidential inquiry and the people will not cooperate. But when there is a will, there is a way. And when there is a good intention to serve the people, to serve our fellow OB-GYN, there is always the people come with a positive response. So Kerala has achieved the best maternal and newborn health statistics. Though I wish to emphasize that despite the difference in per capita income is not much for different from rest of the country. Kerala is not that rich. It is the same socio-economic status, same thing, but the persons like VP Pailly and his team make a difference. So he is regularly publishing, and the second thing that he is regularly publishing from 2004. And I'm very fortunate that I received just 1 year ago his last, that is 2020. So a very, very simple person, and he has the very simple beginning, had education schooling in local schools at Kakkad and Piramam. He has done MBBS from Government Medical College, Kottayam in 1968 and MD from Government Medical College, Calicut. Awarded MRCOG at Edinburgh, UK in 1982 and Fellowship of Royal College of FOGSI in 2002. And at present, he is Senior Consultant and HOD Obstetric and Gynae at Rajgiri Hospital, Eluva, Irankulam, Kerala, and placed the position of the Professor OB-GYN GMC at Thrissur Medical College, at Jubilee Mission Medical College, Thrissur, and Consultant Mother Hospital at Thrissur, Kerala. He has a warm personal life, and he has the brilliant 3 children who are not only in medicine, but in the physics and in the sociology. And we see the very, very simple family and a lovely smile right from he was very, very young to the today when he is with his grandchildren and children. So personal life is something which is actually speaks a lot about any person, and he has led a simplicity, and we really, it is a matter of learning that how the hardworking people communicate and convey the good moral values and the values of hardworking to their family. He has also had an international experience, worked in Saudi Arabia for 6 years and for 4 years, head of the department at the Saudi Arabia Daman in UK for 4 years. And he was organizing secretary of the first All Kerala conference in 1979 and 2006 Kerala in the beautiful city of Kochi, which many of us have been the part. So we can see Dr. Pailly in the dresses of the Daman, and that meetings. Actually, we do attend meeting a lot. Many people do attend meetings, but there are very few people who are that alert, that respond, that make them think that what we can take out best from these discussions. And Dr. Pailly was motivated with this important meeting, which he has kindly shared the photograph, that he started working that in our country, we also can have a confidential inquiry into maternal death. So these are few recommendations. I am not going to detail that it is a recommendation from Why Mothers Die, that is confidential inquiry into maternal death. And he says very rightly that challenges of the Western or the developed world is different and solutions are different. So we cannot follow. Actually, their ways can help us out, but we have to innovate our own solution because we have the different political system. We have a different bureaucratic system. We are catering to very heterogeneous, complex society in India. And these are few recommendations which, as I carry to all my scientific deliberation, that how the simple, like availability of drug and equipment, making blood component available, insurance for the care, accreditation, how professional bodies can help in the accreditation so that we can ensure the quality care. And actually, it is not ensuring, it is about the passion to achieving that we are giving quality care and how we can make the hospital management. He has also taken in the last is his confidential inquiry, that is near miss situation, because near miss situations are much more in number. They are mirror image of maternal mortality. And he again says a very, very important message that we have to bridge the gap in the antenatal, ineffective antenatal care we do, but the quality antenatal care, failure to recognize potentially life-threatening complication by our OB-GYN, delay in referral, lack of adherence to standard protocol, and the poor documentation. So here are the bridges, and we can really focus our future work that these bridges can be gapped, and we have to work together for this. So a very, very simple in sepsis care bundle, he does not go for the higher investigation, but urge that every OB-GYN, every house surgeon, every nurse, that top touch count screen can give you fair idea that this patient is having sepsis and what degree of sepsis, and a very clear recommendation which women need thromboprophylaxis. So these are the few examples that how the India speaks. What I say, it is India speaks and the India recommendation. And as we are celebrating 75th year of independence, this is the way ahead that we must be very, very confident in our knowledge, and we must believe our people. Besides this, not only a very good organizer, very good teacher, he has invented so many innovative instruments. So I remember when he first started aortic clamp, this thing, and we were listening into the conference and a lot of international faculties questioning it. But how Dr. V.P. Pailly is firm enough that we cannot have interventional radiology everywhere. We cannot have those, what we say, a very, very high grade of multidisciplinary, and this aortic clamp really works because you can do the surgery in the short span of time in placenta accreta. Then for PPH, transvaginal uterine clamp, tension-free mesh, which is very, very low cost, and a new design obstetrical forceps. So it is roots, and he gives wings. And his innovation are not only useful for everybody, and they are very, very implementable. They can be used by the average skill of OB-GYN. So this is the transvaginal uterine artery clamp in our all presentation PPH. I always propagate that we should use it, how we can, you can take time in the shifting to OT, you can refer it, and it can prevent altogether. Wonderful research paper he has, and a lot of books to his credit, beside Why Mother Dying, Handbook of Obstetrical Rapid Response Team, Guideline on Delivery and Labor, Why Mother, and the scientific committee member of the FIGO 2009 he has been. So like Dr. V.P. Pailly, few revolutions are slow and silent. They demand our transformation. And here we have the next 30 minutes, we will have a close heart-to-heart talk with Dr. Pailly, that how we should transform ourselves so that we are a very compassionate and skilled doctor, and we serve our population to best of the capacity. So welcome, Dr. Pailly. And the first question to you as a today, that we always think that so many research papers, sometimes multi-centric studies, and especially the maternal death. When there is a question of maternal death, it is always, today even it is that the private sector does not open up, people don't open up, they don't share their true experience. So how could you overcome all the barriers, which we suppose that in India we cannot do it because we have a very fragmented or a diverse sort of health system? So Dr. Pailly, this is first question, but you can say first to all audience who are waiting to listen to.
Thank you, Sadhana. It was great to interact with you. And you gave in about 12 minutes my whole life history and my family as well. And thank you for this opportunity. I know how much involved you are with FOGSI, and you are dedicating your life actually to FOGSI and its well-being. And I can only say best wishes for you in your election campaign. And let's hope that you will be able to contribute more. You have already done a lot. To answer specifically your question about the maternal death audit, yes, we are happy that in Kerala we could have this model, which is followed only in very few countries in the world. To start with, it was in the UK. Then South Africa, when it got independence, it decided that they will immediately take to confidential review of not only maternal death, but perinatal death. And in Kerala, we decided to do that in 2000, from 2004, Jan onwards. And as you said, many colleagues ask how you could do it, because there are so many problems when others who try to do it in other states in India. They said that there are so many difficulties. The most important problem they found was, how can you get everybody together, including the government and the private hospitals? I think the main problem in maternal death audit in our state, our case, our country, and probably in many other countries in the world is that whenever a maternal death occurs, the administrators or whoever is in power, they want to assign the responsibility on somebody and see that that person is responsible and is punished. This thought process is the main problem. I can definitely say, and all of you will agree, that no mother is deliberately killed by the obstetrician. If a maternal death occurs, is the end result of many, many lapses. There are many players in that. In that, probably the major share of responsibility will fall on the people who want to punish others. The administration, the system, the patient herself, the family, the society at large. So then to single out the obstetrician and see that that person is responsible, there starts the problem in auditing. So we decided that punitive action should not be there. And that is what the British decided nearly 70 years ago. They said that every maternal death should be audited by a practicing obstetrician, not by administrators, not by public health people, a practicing obstetrician. Only practicing obstetrician will know the problems that led to it, as well as what could have been done to prevent it. So that is why we also thought that would be the best for us to do. Once you realize that our aim is not to punish somebody, but to find out the factors that led to the death and how we can prevent it from happening again, in other words, prevent it, then I think we'll have the right answer for that. Many people ask us, how could you get the private hospitals, come in line with you and help you like that? We don't make a distinction between private and government regarding audit in our state. In fact, whenever a case record is audited, the people who are looking through that are not aware of patient it was, which hospital it was, which doctor treated. We only go through, so we anonymize the case records and then look through the circumstances that led to it and finally decide whether there was a preventable element. And such elements we try to bring out. Initially, it was through our books, but of late, for the last few years, immediately after an audit meeting, we'll come out with snippets from that audit. That will convey the gist of the findings, so that there is not much of delay in communicating correctable factors to our rank and file. So to answer your question, how we could overcome, I think the attitude of the administration has to change. Attitude of the professional bodies have to change. Attitude of all the obstetricians have to change. We are in this exercise not to find fault with somebody, but to find out what could have been done to prevent it and what could we do to prevent it in the future. Once we have that attitude, I think there may not be much of a problem. The second problem is, of course, obstetricians are human beings. We all have the same traits and elements: jealousy, backbiting, not respecting others, and all this. And getting the consent and respect of our colleagues is important. Initially, everybody will be suspicious. That was true for our state as well. But after 1 or 2 years, when they found that the documents they were kind enough to share with the body was not used for, propagating bad news about them, their management and all that, then more and more people came along. Now it is not a problem for us to get the records, except that administratively, there are always problems. Some of the private management may not take the pains to share it and all that. There's still, some of the new management may be suspicious. So that sort of snags are still there. But by and large, we could overcome this element of suspicion.
Thank you,
Okay.
sir. So this is a very important, very important thing you were that no blame, no punishment. So always there is a maternal death and we always see the first thing that the doctor was suspended from that place. And sometime a doctor is a only doctor, obstetrician, gynecologist in the whole city, in a small village or the town. So this is all. And the second thing is that what obstetrician only understand obstetrician wo, that how we falter in diagnosis, how there can be human resource issue. So that is very, very, I think this is very important that we should, it is neither we are protecting, but we should be very sympathetic to our colleagues. And every system, though we are always analyzing what could have been done. And a third thing that is still all are human beings. So all think that that what is the jealousy or competition, it goes with the human mind, but actually it is the way once any person get confidence in our system, then they are open to it. One important question is to Dr. Pailly, beside obstetrician, and we are having that how come we want to see any obstetrician professional body association, it is FOGSI, it is IMA, that it should be respected by our government and the bureaucrat. So in your all confidence in inquiry, we say that every maternal death to be reported to FOGSI and the government of India. So how could you collaborate with government that you could keep that confidence that the government is also respecting and contributing to it?
Very true. Actually, without government support in the system in India and in states, state health is a state portfolio. So states support is required. Government of India puts in the money. So we have to get Government of India support as well, as that is usually coming through the Rural Health Mission. So we have to get their support. They also will support if they feel that the money they help, we didn't take any support, financial support from the government. That's our thing. We don't take any government support financially, except that they allow us to do it and we give the product to them. We don't take any money out of them. And it is not very expensive from that point of view. Our federation finds the fund for it. We, from whatever leftover we get from our conferences and workshops and all that, we use for this one. So if you take even 1 rupee from the government, then it becomes a problem. And then accountability comes. Government thinks that we are not utilizing it properly. All these things. So we decided that we don't need financial help from the government. The other thing I want to add here. So to get the support from the government, we were lucky at that time to get our health secretary to agree to this point, because as you probably know, there are mainly 4 types of audit of maternal deaths. One is the verbal autopsy. The second is the facility-based audit. Third is the confidential review. Third is the near-miss audit. And the fourth is a confidential review method. These are the 4 types of that. So the government of India's directive was every maternal death should be audited, and at the district level, the district magistrate should chair in that meeting where this is audited in public with the relatives of the patients and even other people who are interested be there and all that. Very often, it is such a humiliating experience for senior obstetricians who are pulled up and blamed for something which is not within their hands. It's very easy for the administration to say, why did you do this? Why did you do that? So our government, fortunately, agreed that they don't want the magisterial audit. They will allow us, CARE-FOG, to do the confidential review of maternal deaths and give them the report. The government health department, along with that, will continue to do the facility-based audit. So the magisterial audit, the district collector supervising and all that was taken away. And that was a big relief for us. Government relied on us and we reciprocated by giving them the product of our audit. every 3 months, senior obstetricians from across the state on their own expense get together, sit together and go through the cases which have been given to them for looking through as an assessor, go through the findings and summarize the findings. This is how we have been doing. One other thing I want to add is any audit is meaningless unless you follow it up with remedial action. In other words, WHO called this as the surveillance, that is the audit, and response to it. For example, we found that PPH was the leading cause of maternal death. So then we started to work on remedies for that. People will say immediately, say active management of third stage of labor. True, that has been promoted. So that is how we went on to work and develop procedures or techniques that will take care of the PPH. You yourself said about the transvaginal uterine artery clamp that we developed. Another colleague of ours in Kerala, Samartha Ram, came out with the suggestion that suction cannula will be a good method to make the uterus contract onto it and stop the bleeding. So with these two innovations in our state, now we can see that PPH is becoming much less of a problem. I cannot say it is still taken up by entire all the delivery points, but it's much less of a problem. We have no way to overcome. This is over and above the active management of third stage labor which we promote. So in other words, the message I have is you do the audit and based on the findings, you have to see that remedial actions are taken. That applies to every major cause of maternal death, not only to PPH. When we found that hypertension was the second leading cause of maternal death, we decided that we have to address this problem. The remedy was easily available. Only thing is not implemented systematically. So we decided how we should use magnesium sulfate, which was not being made available at that time. We made it available across the state. We came out with a standard recommendation of how at the 0 hour it should be given, what dose, by what route, and like that. How after 4 hours you repeat it like that. We also came out with a standard recommendation of how we can control the high blood pressure, labetalol, of course, calcium channel blockers, all these. And we also said that we should start treating hypertension before it becomes dangerous levels. So we immediately said that we should start treating BP whenever it is 140 over 90 or above. About 3-4 years later, Canadian College came out with the same recommendation. And now it is internationally recognized that we should start hypertension treatment in pregnancy, not when it is 110 diastolic or 160 systolic, but when it is 140 systolic and 90 diastolic. So from our observations, when we found hypertension is the cause, later we found that amniotic fluid embolism is a major cause. What can we do to prevent it? Very difficult. But looking through the case records, we found that there are probably some other predisposing factors for that. This became more when there was hyperstimulation of the uterus. So we standardized how we should induce labor, stimulate uterus. And also we found that, unfortunately, there were some people with smooth muscle relaxants like dotaverine, epidocin, when a woman is in labor 4 centimeters and beyond dilatation. That's the time when cervix will anyway dilate fast. And then people are promoting to give these drugs, which will make the uterus, the blood vessels remain open. And we thought that probably that also may contribute. So we had to do a big, struggle to see that this practice, which was unfortunately even recommended by our own national body, was stopped from our state at least. So like that, whatever we find as on analysis the cause, we try to bring out remedial measures as well. Some of them may be beyond us. For example, if transportation is a problem, we cannot do it, but we persuade the government to work further on making the ambulance system better. We persuade the government to make sure that blood and blood products are available and start blood bank in every district. Like that. So maternal death audit by itself is meaningless unless we follow it up with remedial action.
Thank you. I think you have given so many points which I wish to distill out of your all discussion. First of all, that is the financial independence. You very rightly say, because it is something very practical, that if you take something from government or something, it is making a lot of pressure on us. And a very, very important thing which is actually not discussed, that we have to utilize our professional bodies finance for the all the good reason. It is am I audible, Dr. Pailly?
Yes, you are. Yes.
So this is again because we have to work think in that way, that whatever professional bodies we have out of anything, out of conference or something, that should be utilized for the benefit of all. And the third, very, very important, that life always teaches us. Even in death, it teaches it, in criticality, it teaches us, but we have to be ready with the lessons. So we have to be very ardent. What you say, that every story, what you say, every maternal death is a story. And what could be done, that could we have, that the start of antihypertension at this stage, transvaginal uterine clamp, a wonderful, very, very simple innovation of Samartharam. So this is that we should not only see, because only by counting waves we cannot change. We have to plunge into it. And for every situation, for every key cause of maternal death and criticality, actually your review gives a very, very clear and the simple message what should we do. And that respect with the all hard earned effort of you and all OB-GYN and all people, that owes a respect to the government. And I hope that when we do something for the good of everyone, then government is bound to listen to us, like back in Good Road, and we have a centrally controlled ambulance system, so everybody can avail the 108. And even in Jonat, we said the water ambulance is there. So somehow only this type of work, which speaks for the people, as well as speaks for the honor of fellow OB-GYN. It is not only that sometime today, it is an environment where we think that the interest of people and patient are different from the interest of doctor. But actually our interests meet at the same point, that is a good care, happy care, compassionate care. And your way of thinking and acting is that be compassionate to people as well as be compassionate to our fellow OB-GYN, respect them. We should not try to utilize anything for and against them or for something. And that respect have actually came out with the cooperation and belief of all OB-GYN in the system, that it is all for improving ourselves. So wonderful input, and we look forward that it happens in all states in our country. Now, coming to your innovations, you talked about transvaginal uterine clamp, aortic clamp. I have found that a lot of questions you were facing when you were presenting in 2004 and 5, and you were all determined that it works, it works. There are so many questions. So during surgery, tell us the secret, that we all are doing surgery, but we are not coming up with the... hello, Dr. Pailly? Hello. Pranjal, Doctor, am I audible?
Yes, ma'am, you're audible.
Dr. Pailly, I'm not seeing actually.
Ma'am, actually, he has disconnected his call. Hello. Ma'am, can
hello.
you ask him to join on the same link?
Yes. Phone hello, some disconnection happens. Join, please join. Anna, it is on your mail. It is on the mail. Please join.
All fine, the ma'am?
He is joining just.
Okay.
If there is any problem, you can also call him. So it is resend the mail. Same
You just send me his mobile number, ma'am. I'll share the link on his WhatsApp.
मैं chat box में कर link है उनके पास chat box में.
He can join on a single click, ma'am.
Yeah.
We don't have any issue at our end, ma'am. I think his network,
Okay.
he has lost his network, something.
Okay. Yes. Thank you, sir. So we regret audience that a little bit due to internet issues. So what make you think during surgery that you could come out with such a simple innovations, Dr. Pailly? Unmute, sir. Unmute. Sir, unmute yourself. Yes.
Yeah, you were talking about innovations. Yeah.
Doing surgery, but we are not innovating. So how come you could?
No, thank you. I think that saying that necessity is the mother of innovations is very true. And I cannot say I am with that much of innovative mindset or anything, but whenever there is a need, connected. Whenever there is a need, then we do try to find a solution for that. The typical example is we are getting here. You are able to hear me, Sadhana? Yeah, you are
loud and clear.
You
yes,
are muted. Yeah, you are able to hear me. Okay. So for example, in 2005, when we started the audit, we found that the number of patients with placenta accreta spectrum was on the increase, and that continued to rise because of the rising C-section rates. Everywhere in the world it happened. So then how to tackle it? Looking through the literature, we found that in the West, they tackle it by assigning these cases to selected hospitals with the big teams to tackle it, with interventional radiologists putting balloon into the aorta or in common iliac artery or even internal iliac artery like that. And we could never imagine having that facility in our state. But the basic principle was you cut off the blood supply to that area temporarily. So then I looked around to see with my vascular surgeon colleagues whether they have some clamps which we can apply. They have plenty of clamps. If you look through the literature, there are so many clamps available. But the problem is it needs a vascular surgeon to dissect the vessel and cross-clamp it. That is not possible for an obstetrician or in a center that's available in our state. So we went around thinking about it and then developed this clamp, which is so simple as the aorta clamp that we developed to occlude the aorta when we are doing the placenta accreta spectrum. If this is the aorta, all that we wanted to do was pull it up with a Babcock, and then the aorta clamp is applied, full thickness of the aorta, like that. And once you occlude it for a few minutes or hours, when the surgery is on, blood supply is cut off. So much simpler, cheaper, and doable than using the interventional radiologist to block the aorta with aortic balloons. This is an example. We had a need. Our mothers were dying on the table, even in the medical colleges, with the available facilities and senior obstetricians. So we had to work out a solution. So necessity, out of that, we thought what we can do, and that is how the aorta clamp was born. the transvaginal uterine artery clamp and later a transabdominal uterine artery clamp itself came because of the need to immediately arrest the bleeding. Even though Samartharam came out with his suction cannula, which is a very innovative, very useful measure, especially after induction of labor became more common, we found that the lower segment gets ballooned up. The suction cannula that he developed, we found was not that effective because the lower segment ballooning out and into the vagina like that suction may not make it collapse. So we thought a clamp to cut off the blood supply to the uterus by blocking the uterine artery will be an apt method which can be applied transvaginally. And that is how we developed the transvaginal uterine artery clamp. In obstetrics, we all know that instrument delivery is completely being abandoned. If at all people do, they go for the vacuum only. But there are situations where the vacuum may not give enough traction force. It may be a higher station, you need more traction. And we wanted to keep alive the force of delivery. But when you look at the forces that's available, the assist traction forceps available, they're so big, especially for our Indian women, they cause so much damage to the vagina, to the perineum, and of course to the baby. So another need that came up was, suppose you have an extreme preterm baby. If you use the conventional forceps, the baby's head will play between the forceps blades. So we developed mini forceps. This we call the mini forceps, which can be applied to all those babies which have to be delivered either during cesarean or through vagina, baby weighing less than 1,000 grams. So like that, depending on the need, we thought what we can do. But unfortunately, the situation in India is not all that conducive for innovations. See, I applied for the aorta clamp in 2012. And the body gave the permission or the certificate saying that it came only after 10 years. Whereas abroad, they would have grabbed the idea. Some companies would have come forward, manufacture it and sell it with such a profit. So like that, we have problems in the patent body in India is, I would say, very unfortunate. They are not all that proactive. We don't have the backup of biomedical or biophysical companies or innovators or universities coming to support practitioners. Only the practitioners know the need and possible solutions. And if only there is collaboration as it's in the West, that could have been much better. But every one of us has the opportunity to think of solutions for the problems that we face. And I am sure going carefully and systematically without causing problems to our patients, we can slowly bring out changes like this. That's my feeling.
Thank you very much, Dr. Pailly. First of all, that is the need is invention of time. So nature gives us wisdom that how we can do, and we always think as a surgeon, as a clinician, we are always thinking what is happening. And a very, very important point that this is something, a very, very important thing and something aching for us as a countryman, that we don't recognize our innovation. It is not conducive because the same sentiment with Dr. Sanjay Guha, who has the reversible male sterilization, and he is now like, okay, it is around 20 years. So he says that being like innovation in India is something very, very painful. Like we, a little bit self-doubt we have about ourselves as a race or something. And this is actually right time that like everything has got its own utility. It is not, anything is not going to 100% successful in every situation. So we have to come with this, all queries, if this is issue that we can do this thing. But important thing again, very, very important, and this is a sore point, it is a aching point, that we are not encouraging to our innovator. We have a lot of self-doubt as a race still. And again, that is that positive environment with the politicians, with the bureaucrats, and with the, what you say, the biophysical, biomedical organization. So this is again the thing that like we can change it. Will take time. It takes a time because something very deep rooted. But we could feel your pain, but because how the company could make it, like even like simple transfer, and it will cost mercy 2,000 to 500. What is the instrument? It is not the lakhs of rupees which you are investing in so many instrument, which is not a public, which is not a issue of the majority of people. So thank you very much for like putting up all these issues. And then I will say again, another, you are a very, very simple person in dress, in your walk, in your talk, very, very soft spoken. So with the immense in-depth knowledge of concept of medicine, obstetrician, gynecology, knowledge, skill, how could you communicate? Like I have seen your workshop and you stick to very, very simple thing, that how to do the uterine massage or how to put this thing, cervical tear suturing. So what's your message to our all teaching, when now today teaching is so much high technical and people are putting on Instagram and something? How do you say that, what is the future of how we should go ahead with the teaching of OB-GYN science? You say this forceps is obsolete, because once upon a time we used to apply like so easily forceps, but today everybody is fearful of it. So your message for it?
I think we seniors have an obligation to make sure that the talent that we got, some of them inherited, some of them taught by our seniors, some of them we developed ourselves, they have to be passed on to the next generation. So our experience sharing is important. And when you talk about things with our own practical experience, I think we don't need many high-tech gadgets for conveying messages. For example, for the aorta clamp, we need only a tube to show that the aorta can be clamped like that. But we can also convey that it has to go full thickness and all that. Similarly, for the transvaginal urinary clamp, I have a simple model of a uterus which can be used for teaching that, like that. So I think what's important is when we talk from our own experience, and then we don't need much high-tech gadgets to convey the practical points, especially in obstetrics. Obstetrics is a very simple science. It's actually one of the branches of medicine which doesn't need all that high-tech things. So we can easily, I think, convey practical things when it comes from our own experience. And people hearing also will understand, oh, that problem we also had. Oh, this is a solution for that. That is how they take it. So I think when we talk from our own experience, rather than just copy from somebody's literature, people coming and talking about that college said like this college said like that, this meta-analysis was like this and all that, I get put off. So we don't actually even listen to that. What we want to hear is people who have assimilated that, put to practice. For example, I don't know whether you know about it, Hoffmeyer, when he came for one of our meetings, he said how he was trying to deliver a shoulder dystocia case by the posterior axillary sling traction with the aid of a model and a tube, a Ryle's tube, he could show it. So some of our colleagues immediately took to it because this is a day-to-day problem that they are facing. Very simple. And to add to that, I can say that to get that sling around the posterior axilla, you can use my transvaginal urinary clamp also that can take it around that. So like that, we build something somebody has innovated, we add further on to that. Dr. Samartharam came out with the suction cannula. We found that that is a good concept, but in practice, sometimes there are problems. For example, when you take the cannula and try to connect to the suction tip or the suction tube, it doesn't fit in there. Every second that we waste fiddling with all these things is a problem. So we suggested, why don't we have a disposable plastic cannula, which is available, ETO sterilized. Just open the pack and put in. We can immediately get the negative pressure. There is no question of washing, because washing off the blood after the cannula had been inside for a long time is not that easy. So we can sell it without much added cost to a usual suction tube that all of us use in the theater. The suction tip that they provide, we change it with a multi-hole suction tip. And that is how what we are promoting in our last labor congress last week. So like that, we build on what other people have done, not taking credit away from what they did, That is very important. The innovators have to be respected and given credit. And then we can pass on the experience that we had to our next generation. The obstetric forceps, the one I showed is the mini forceps. The standard forceps that I have developed can be used as a low forceps, as an outlet forceps, and as a rotational forceps, because it's a relatively straight forceps. The problem is, being in a setup like what we are in smaller teaching centers, we may not be able to convey to us. So we have to find the forum to convey the message in practical terms. Last week, actually, Sadhana, we had a labor congress, which we tried out, demonstrating all these things to the wider body of the practicing obstetricians in the state. So that dissemination also is our responsibility.
Thank you very much, sir. This is very important that we don't actually, we have to, when we have what a low resource, we are the complex country, we are very rich. So sometimes I feel that somehow the environment is being overshadowed by the concern of very rich people who are few section, and the majority of needs are not taking a backseat. So the obstetrical art of which the Indian teachers and OB-GYN are very good in it. Why we are good in it? Because we are catering to the largest population of the world. So we are having more experience that way. Important thing is that we disseminate, and rightly says that we are also getting trouble that every time we say this body says this body says that, but we actually are not taking inclusion of our own obstetrician. Just now we just 1 hour before we have a West Bengal Society, and one doctor says, Dr. Atin Haldan, that once during internal iliac artery, he was so honest and clear to it that he damaged external iliac vessel was disturbed. So she had a problem with it, but after 1 or 2 years, she had a little bit difficulty in walking, but patient is live and she belongs to labor class. So these are the few things that with every instrument, with every technique, we have the issues, but we have to include, we have to take honor that expertise, experience, what is happening, and we cannot sway away from it. So Dr. Samartha Ram, it is really pleasure that since my beginning as a chairperson, Dr. Nalini Mishra's balloon, Dr. Samartha Ram Kanula, Dr. Panikers, we always invite them in person on virtual, and we are so many places we are doing workshops, VPH, and everybody says that Samartha Kanula, we say it never fails. Actually, it might be having, but many people have very good response about it, but still we don't have the commercial production, and what you say that the disposable one we can have, especially in aortic lamp, that is not, these things are not available, they are not being used still by every OB-GYN. So again, a very, very important thing that honor every innovation, try it, and learn from it. We can have a little better innovation like obstetrical forceps, what you have said. So thank you very much. And I think the last 2 questions, that India is changing a lot. India is changing a lot. It is 3rd largest economy. Government is coming with so many medical college. It is in every city. So and the upcoming obstetrician gynae sometimes find it difficult to what they should do with their career, that it is money and fame is only with the IVF or endoscopy, and they don't want that who will say 24/7, obstetric is a bloody unpredictable business, people are, media is so bad. So how come your message that we bring the best mind to OB-GYN, and we can say that every specialty is fine, every super specialty is fine, but our basic healthcare to everyone is so very important by us. So what's your message to young OB-GYN that how they should be brought to the mainstream of OB-GYN?
You're very correct, Sadhana. Unfortunately, even those who take up obstetrics and gynecology soon deviate towards IVF, fetal medicine and all that, and hardcore obstetrics is not an attractive subject. I'm not very much concerned. I am sure the trend will change. This is a pendulum swinging in one way. There will be enough number of well-motivated, kind-hearted youngsters coming to obstetrics because it is such a thrilling subject. The thrill of practicing obstetrics, I'm sure people will understand. There is a charm towards getting more money and lack of night calls and all that, but great minds will come. I'm sure. I'm not worried that this specialty will die out. As long as human reproduction has to continue, I think obstetrics will have attract people with good intention and mind, all that. But having said that, we should make sure that even those who are prepared to, lose their night sleep and all that are adequately rewarded. So the obstetric practice has to be rewarded well. Otherwise, you cannot have saints only coming and practicing obstetrics without any returns. We have to adequately compensate. Then only there will be people to come to obstetrics. So having said that, okay, one thing we have to tell the youngsters is, if you practice obstetrics, that's the riskiest of specialties. Then the charm of practicing that, the self-respect the person should feel, should be made known to all these youngsters. And I'm sure there will be more people coming. And second thing is, at the young age, especially youngsters, when they think of starting a family and all that, they need a lot of money these days. And if the salary is not adequate, we cannot expect people to, forgive and then still stick on to it. We should make it rewarding financially as well on one hand. Also, we should tell the youngsters that money will come. See, our experience was like that. I don't come from a rich family, and we were never in need of, anything that we wanted, we could have. Maybe in a lower scale, smaller scale. We had a car only after a few years. Even to have a scooter came after a few years of our starting the family. The first car I could own was a second-hand or a third-hand car when I went to UK, not in India. Like that, it still come. So if you put your most important emphasis on money, of course, there'll be a problem, but money will come. That is the assurance I can give to our youngsters. Even if you take up obstetrics, there will be money coming. There will be respect from our colleagues. And of course, your self-satisfaction for practicing the most riskiest specialty. That sort of a self-respect is important. It will come.
Thank you, sir. So very rightly says, we always say that money is a byproduct. We go on working and it comes you in initially slowly, and it comes to you also in abundance, and a lot of fame and name is there. So nothing what I say, that obstetrician, surgeon, that no, you don't want to wake up in night. But I say once you are hooked to wake up in night, you will miss that. Oh, today I could slept and it was something missing. How could I slept for 5 days? It is something missing. So thank you very much. This is very, very important message, that don't be in hurry. This is a very, very satisfying. This is what we can say, the medicine, the chronic disease. Obstetrics and the gynecology, mostly the business, when you have the reward, the patient delivers, everything is fine and everyone is happy. So it is very contending and rewarding. It is a generations of relationship. Everybody will come with their children and the grandchildren, and this was born in your hospital by your hand. So very, very important. And when Dr. Pailly says it, then it really means that everything will come to you, money and the fame in this very, very challenging business. And finally, the last question is that everybody says that the people are changing, people's perception are changing. So nobody want to wait. So many people's outlook to the doctor is changed. We just this FIGO president that we have a artificial intelligence, and we have to go be ready for the future when patient can monitor, and where will be our role in the next system, like telecommunication has come, e-consultation has come. So what's your message finally, that how we make ourselves relevant, very, very useful, and yet retain the principle of medicine, that is a compassionate care. So what your challenges you perceive in the next 5 or 10 years, and how we should be ready for that?
You are very correct. Changes are happening, and the expectation of patients, the society, everything is changing. So we have to change ourselves. We cannot still stick on saying that all that I need is 2 fingers to do a PV and then do it. We should adopt technology as it comes and take advantage of it. For example, fetal monitoring. We should not shy away from using it. So new technology we have to take. We have to insist that there are more and more occasions where we may have to do cesarean. We cannot say that 10% cesarean rate is all that we need and the rest of it all right. No. expectations are changing, our knowledge has changed, we have to adopt. But more important, I think, is obstetric practice has to be a teamwork. You should have a team to practice. Just solo practice, especially in a hospital setting, is not likely to be practical. You cannot be there 24 hours of the day, 365 of the day. So you should have a team to support you, and you should have colleagues who will understand and mutually supporting. I think for the future, one of the main messages I feel is it has to be a team practice, whether it is under the government, whether it is a private. And that is why we made to the government a recommendation that no delivery center should operate without at least 3 obstetricians. Then only we can cover one person may be sick. You cannot say this center is closed now. So we should have at least 3, if not more. So this solo practice, I think, is not likely to happen. We have to adopt things and provide financial support. For example, the delivery table itself. Now there are so many changes, small changes. We are working on it ourselves of comfortable position for the patient. We may have to spend a little more, but we should spend on that rather than have that steel tabletop. But I would say where the dead body is kept for autopsy, like that. Our delivery table is just like that. Not even a leg support. That should change. We should have cushioned seats, cushioned bed, like that. So we should adopt technology as it develops. We should have a team practice, and we should have this feeling that obstetrics, the very word is that being a companion to the woman when she is in the most distressing time. That is how midwifery came up. And obstetricians are midwives, probably technically a little more trained. So that companionship to a woman in labor is the most distressing time is to be maintained. The question is, should we abandon all vaginal deliveries and do all cesareans and make it a surgical specialty? I think that is not the right way to go. We may have to do more cesareans than where our previous generation did, but not that 100% cesarean. That is my feeling at the moment anyway. We can have safe vaginal delivery with the new monitoring systems and with collective responsibility without getting us blamed. I think then obstetric practice will be rewarding and much less risky than what many people are afraid it is. Thank you.
Thank you, Dr. Pailly. So invest in labor room, invest in good equipment. And these are the simple technology, not very hard to reading a CTG, having 2 or 3 machine, not 1, 2 or 3 machine. And very, very important that today is the work of collectives. We are together because the IT people are there. There are so many people. So the collective, it will improve our mental health as well, that we make a team or 4 or 5 people, which include 2 or 3 obstetrician, neonatologist, pediatrician, anesthetist, and we will have a good circle of friends, because that mental health is, because I am as a doctor, Dr. Pailly as a doctor is very happy person, but we see medicine is not a very a satisfying job. So this is very important that we can take care of our all personal responsibilities, all mental health. If we practice in group, that is the way ahead. And we can have always investing in the technology, adapting technology. That is very, very important. And always that this is believe in ourselves. So this is very, very important. And how the people, we have to change the people expectation. Once upon a time, cesarean was not accepted. Now we identifying IUG, so many things, and people are accepting it. So we have to adapt to all the issues, artificial intelligence. And what Dr. Pailly says, that everything will enhance our satisfaction, our quality of work, and we should be open to everything. So thank you very much, Dr. Pailly. We are just in time, 8 to 9, and that is one of the memorable conversation, and I am fortunate that I could have that exclusive time. And once again, we will grateful that you kindly consented for this conversation, and we look forward always for your guidance, for your very, very well experienced comment and the ways how we should go ahead. So thank you very much, Dr. Pailly, and last word from you to audience.
Thank you very much, Sadhana, for this opportunity to share our thoughts together. I hope that we would have given out some of the messages which may be acceptable or adaptable. And let us hope that there will be more youngsters coming forward to take up the specialty rather than shy away from it, and help our women in the most distressing time of their life, that is during childbirth, and take part the joy that they are getting when they bring a new life into the world. Thank you very much, and best wishes for your position. Thank you.
Thank you, sir. Thank you. We thank all the audience for being with us, and we will soon share recording link. Thank you, Corona COR-CONNECT, for giving the platform, and thank you, Pranjal, for bearing with me all insistence on the
No worries,
flyer
ma'am.
and
It's my
everything.
pleasure, ma'am. It's my
So
pleasure.
thank you. Thank you.
Thank you, sir. Thanks a lot for your time. Thank you so much, ma'am.
Thank you.
Good night, sir. Good night, ma'am.
Good night. Good night, sir. Good night.
Should I end the meeting, ma'am?